sometimes you have a tooth position problem, sometimes you have a tooth force problem, and sometimes you have a tooth contact time problem. So time, force, position. A crack is an end product of overload. So risk factors for cracked teeth, right? So if we think again that is to do with overload, right? When you have a patient who's got large amalgam restorations, MOD, I don't remember the last time I removed an amalgam and I didn't see a crack underneath. Why is it that maxillary premolars are more likely to crack than mandibular premolars? This is really fascinating. If all you do is remove the crack and put a composite, the composite will also fail through overload eventually. So you must change something about the environment to reduce the crack propagation. I've been involved in dental communities for many years now. I run my own community, the Protrusive Protrusive Guidance. And one of the questions that keep popping up week by week, month by month, year by year, it's just all seasons, all time, is about cracked teeth, management, diagnosis, cracked tooth syndrome, and getting very patient specific, describing the symptoms and signs, and all the discussions are about cracked teeth. So there's still obviously some uncertainty about the best way to diagnose and manage cracked teeth, which is why we created this episode. I know it's part of the PS Protrusive student series, but honestly, the way I ended up explaining cracks and my philosophy and the way I think about how cracks form and how the management very much depends on so many patient factors is pretty unique, I think. I don't think I've ever spoken about cracks in this way, and I think it ended up being a really wholesome episode. Again, thanks to some wonderful questions from our student, Emma. Now, alongside this episode, in the show notes, we've put together some essential reading and some great PDFs with excellent data and visuals on cracked teeth. And I mentioned a good literature review on cracked teeth that's also referenced in the show notes. If you are watching or listening on Protrusive Guidance, just scroll below and download it. And if you haven't yet joined the community, what are you waiting for? We're waiting for you on protrusive.app. I really enjoyed recording this episode, Emma, and I hope you enjoy listening or watching it. Oh, and this episode is eligible for CE. There was so much substance. So whether you're going to collect CPD hours or CE credits, wherever you are in the world, this episode is eligible again through the Protrusive Guidance app. Let's catch the main episode. Emma, the Protrusive student, welcome back to the Protrusive Dental Podcast. It's so nice to have you. Yeah. We're talking about cracked teeth today. Look, I can talk about cracked teeth for days. It's something when in the earlier episodes, one of the early episodes is titled I Hate Cracked Teeth. I still hate cracked teeth. We all hate cracked teeth. No one likes cracked teeth. But you know what? Over the years, I've learned so much about cracked teeth. And now I've got some things to share with you. I'm really excited to share with you that will really change how you approach cracked teeth and how you communicate cracked teeth and all that kind of good stuff. But what I want to start with is what's more important to you as a student. You are connected to students and young dentists better than I am, right? You are right there in the trenches, okay? Like asking these questions that no one wants to ask anymore because they're afraid to ask, right? Because maybe I should know this already, but you have no fear, no shame because you're a student. It's fine, right? So it's cool. Like you don't have to know everything, and so you're in a position to represent everyone and ask those questions. So firstly, Emma, give us an update. How's final year going at uni?
Yeah, final year's going good. Just the same as when I caught up with you a couple of weeks ago. It's just, our finals are out the way, so I've got a lot more time in the evening to sort of decompress and focus on the things that I know will be in my book the day after. So if I've got a crown prep or something that I need to look up on, I know what I'm going to be doing. I can go home and I can focus on that for the next day rather than stressing about exams. But it's good. It's going really well. It's going good. I'm enjoying it.
Good. You made me remember something, right? Like, I was just trying to remember, how long does it take for you not to, like, for example, I remember being a student and if you had a root canal the next day, you'd have to like revise the steps for a root canal. Yeah. You do that, right?
There's a lot of things that I don't do that for anymore, where I probably would have in about third year, something like that. But for something like a root treatment, I'll always just remind myself, just look over, make sure that I know, because I'm always going to be asked questions. So just to keep on top of everything, I do still do that. Yeah.
I won't forget, Emma. I was playing FIFA, right? That's what we did. With we went to a clinic and we come home, we just play FIFA. That's all we did, right? So maybe I don't know if student life's changed yet for the guys or not. But that's kind of how we live life. And so I remember playing FIFA, and it was like 20 minutes to go until my clinic starts, right? Okay, one more match kind of thing. And I was there I was living in the fifth year, I was third year, and I was just revising with him. Okay, I've got a wax jaw registration for complete dentures. Let's go over the 5 things I've got to check for while I'm button mashing and playing kind of thing, right? So it's a just-in-time learning, it's revision. I was just trying to remember, as a dentist, a qualified dentist, how long did it take me before I was comfortable not even looking at my day list anymore, and wherever life's thrown my way, I'll be able to deal with it. And it's a good number of years, maybe 5, 6, 7 years until
Yeah.
until I got to a stage where, whatever comes through my door now, it's okay. I got this, right? I think the only caveat here is if you go down the path of comprehensive dentistry, right? And there are multiple steps involved and long appointments, you have to do your due diligence. So sometimes you're checking the day list not to let me revise the steps for how I'm going to raise the OVD and do the mock-up and preps or whatever. It's more, has the lab delivered the lab work?
Yeah.
Let me make a checklist to make sure that my nurse is going to be happy supporting me on that day for that treatment. It's other challenges that it brings. And so it's, it's all fun and games as long as you relish it and enjoy it. And part of the enjoyment is that every patient is different. Every patient has unique challenges. Even cracked teeth in one individual is treated completely differently to a cracked tooth in another individual. So with that, Emma, what would you like to know about cracks?
Yes, so this idea about cracked tooth syndrome episodes came to me because it was one of the first questions we had in our finals, and it was one of the last lectures that we ever received in fourth year. And at the very end of the year,
what's a typical finals question look like about cracked teeth? Amuse me.
So I think for the topic was cracked tooth syndrome. And one of the first questions was, give me however many modalities of diagnosing a cracked tooth, signs and symptoms, things like that. I'm one of those people that typically forget everything that is asked as soon as you walk out of an exam, but I remember this one. And I remember it because it was one of the last lectures that was given to us. And because it was the last one, it's not something that I really looked over. And it was the first question. I'm sure it was one of the first questions in the paper. And I was like, oh no.
You were kicking yourself.
Yeah, I was kicking myself. So the first question I had for you was, just in your own terms, what is cracked tooth syndrome, and does it differ from like a fully split tooth?
Okay, great question. So cracked tooth syndrome is a set of symptoms and signs that tell you that's why it's called syndrome, right? It's a set of symptoms and signs that lead you to a diagnosis towards, okay, this tooth is cracked, and that's the cause of the symptoms. Symptoms could be like cold sensitivity, hot sensitivity, classically pain on biting, especially on the release. So that's like the classic syndrome, and then you kind of make that diagnosis. The reason why it's difficult to diagnose sometimes is because it's not like it's not easy for patients to pinpoint exactly where the pain's coming from. Quite often with pulpitic pain, like it's somewhere right around here, and as you know, it spreads, and that's a pulp involvement. The other one is that these cracks can sometimes be very difficult to see. And only when you start wearing more magnification, and like literally more and more magnification, you can start to see it. And just because a crack looks innocuous doesn't mean it can't actually be responsible for the patient's pain. So these can be some challenging factors. Now, how does a cracked tooth syndrome differ from a split tooth? Well, split tooth is like imagine a spectrum, right? Split tooth is like, okay, this tooth is absolutely shot, right? Split tooth is like vertical root fracture in a way, right? So it's completely split, it's vertical root fracture. So on one end of the spectrum, that is like completely hopeless prognosis. Is that what you're expecting with split tooth?
Yeah, so from my understanding, like cracked tooth syndrome, you can have pulpal involvement, but you don't need pulpal involvement to still get symptoms. But then if you've got like a fully fractured tooth, I don't know if that would even come under like cracked tooth syndrome. I don't really know.
So split tooth and vertical root fracture, like the difference between them is kind of academics, like what started it. The end result of both those is that the tooth is for the bin, right? It needs a forceps. So just like what I'll do is in the show notes and in the student section of the app, I'm going to put the American Association of Endodontics as a whole guide they've got on cracked teeth. Really good visuals, absolutely fantastic. And the way it shows the visuals for a split tooth is something that starts by the cusps, and the crack goes all the way down, and then now the tooth is like in two pieces. Imagine a premolar with the buccal cusp and the lingual cusp like completely split, and that tooth's unrestorable. Whereas a vertical root fracture we commonly associate with like a upper central that's got a metal post inside. The crack started at the point of where the post is, right, where that stress is, so it's subgingival, and the crack extends upwards. So either way, when you look at the end product, they're both shot and they're kind of like massive cracks. So at one end, you got the split tooth and vertical root fracture, but they all have to like develop into that. There's often the initial crack. Okay, now ignoring the whole vertical root fracture, let's go with split tooth. Every split tooth begins life with a more innocuous crack higher up by the cusp. And if you're lucky, if a patient's lucky, the direction that crack travels, it kind of goes, like, let's say marginal ridge, but then it starts to go more buccal or more lingual. So if it's going more buccal or lingual, what will be sacrificed? When that breakage event happens, when that force exceeding event happens, what Emma will be sacrificed?
So one of the cusps?
Exactly. So that's when you get like someone come in and the cusp is broken off. You must have seen that, right?
Yeah.
Right?
Yeah.
So that's fine. But if the patient's unlucky and the trajectory of that crack is going straight down into the gingiva, eventually, and then it's going through the floor of the pulp chamber, if you like, and eventually the whole tooth is being split, that's way more advanced. So there is like the very tiny crazing in enamel, then there's a crack that goes further into dentine, then that crack kind of propagates and goes spread across, and it goes subgingival, and our job is to really intervene in a timely manner. So it's a difficult one, because if we all lived to age 400, right, then every one of us, no matter how much low force you produce or I don't clench or whatever, every one of us would all have cracked teeth, split teeth if you lived to age 400, right? Now, some people, they generate so much force or various other factors, anatomical as well, that they're able to split a tooth in their 40s. Whereas someone in their 80s may do it as well, but it kind of depends on what kind of pressures. Ultimately, a crack is a what's the best way to describe this? A crack is an end product of overload. Overload is a process. There has to be some degree of overload that is beyond the adaptation of the enamel and dentine. That flexure. If you imagine a molar, Emma, and every time you're chewing, there is, believe it or not, the cusps are like moving away from each other. The tooth is flexing. It's hard to imagine. But when you start getting a crack, then those cusps, they start to flex even more. Like imagine microscopically, they're waving around. And then as the crack gets bigger and bigger and longer, that sort of waving around gets more and more. And then that just makes the situation worse.
Yeah. So I was going to ask as well about particular risk factors. So I'm guessing the number one is things like bruxism, parafunctional habits, things like that. I was also going to ask if there's certain teeth that are more commonly affected, like i.e. molars more than a central, like more force put on those teeth.
Okay, these are great questions. Let's do it in two parts, okay? So risk factors for cracked teeth, right? So if we think, again, that is to do with overload, right? When you have a patient who's got large amalgam restorations, MOD, I don't remember the last time I removed an amalgam and I didn't see a crack underneath, right? It's just a nature of it. You got this stiff, really strong metal restoration, okay? And every time the patient's chewing, those cusps are flexing. That metal is not bonded to the tooth. Those cusps are flexing. And those often those big MOD cavities, they render the walls very weak and flexible. Therefore, you're more prone to getting a crack. So if you already have a large restoration inside the tooth, that's like, the more than a third of the isthmus, if you like, classically as they say, right? So the bigger the restoration in a kind of buccolingual direction, and the deeper the restoration, the more the tooth's going to crack. It's a bit like if you get a virgin tooth and you do those experiments that you see whereby they load and load and load a tooth until it cracks, okay? You know that the virgin tooth is going to survive until a very high load. Whereas a tooth that is essentially got a big hole cut down the middle, because all you're replacing with that hole is a metal. Metal's not protecting that tooth. So essentially, you have this naked tooth with a giant cavity and you're loading it. You can imagine that at 20% of the force of what it would have taken to break the virgin tooth, that tooth's going to split completely.
Yeah.
So having a large restoration is absolutely a risk factor. The other risk factor, and sometimes I see cracks on virgin teeth, so teeth that are completely unrestored, and this is a red flag for a high force patient. If you see cracks on virgin teeth, then that is something to really pay attention to. So this could be someone, and what I like to, in my occlusion stuff that I teach, this is how I like to break it down. Please, Emma, let me know, because there's very few people have heard this spiel. I'm working on like the ultimate occlusion lecture 2025, 2026. Like every year I try to make like break down the occlusion, and this is my new way of presenting it. So let me know what you think. First person ever to hear it, right? If we, like, obviously the joints are very important, and if you change anything about both joints or one joint, both TMJs or one TMJ, then you change the occlusion, okay? But when we're students, young dentists, it's very difficult for us to think in that kind of plane. We want to just, let's think dental for a moment, okay? Let's think the teeth together. And sometimes you have a tooth position problem. Sometimes you have a tooth force problem. And sometimes you have a tooth contact time problem. Time, force, position. Okay, so stay with me now, okay? With the position, okay, if two teeth, let's imagine premolars, okay, because that kind of leads on to your second question, which teeth are at risk of fracturing? Okay, well, premolars, classically, very steep cusps, okay, and if you keep loading it, they're the flexure and they are very prone to vertical root fractures and split tooth. The premolars are very prone to that. But let's imagine a upper premolar, when you bite together, the buccal cusp, or the cusp tip of that lower premolar, sits right in the middle of the fossa. The cusps are not bending. They're not asked to be bended in any way. However, if the lower molar is a little bit off and maybe it's a more buccal position, can you now imagine that with the upper premolar, the force contact is not in the fossa, it's somewhere up the buccal wall? Do you know what we call that contact? Go on. It's called an incline contact. Don't worry, I had no idea when I was your stage. I had no idea it's called incline contact.
I didn't know that. No, I didn't know that.
It's an but can you imagine what I mean? Like it's not like in the flat area. It's on an incline, right?
Yeah.
So you can imagine you're loading the incline, and what's that incline exacerbating? What's it encouraging? It's encouraging that buccal cusp to flex away from the tooth.
Okay.
So that is a tooth position problem.
Okay.
Loads of our patients have really suboptimal occlusions. They've got incline contacts everywhere. In nature, we see incline contacts. So why isn't everyone destroying their teeth? Okay, well, because position is one factor. It's not the factor, it's one factor. So tooth position and their malocclusion can predispose someone to a crack. One. Number two is tooth force. Can you guess or can you extrapolate where I'm going with this tooth force?
Like bruxism habits?
Bruxism, yes, but bruxism is also linked to the third one, which is tooth time contact. But yes, so essentially you're overloading, so clenching, okay? So active clenching, getting your master and temporalis and medial pterygoid muscle. So that one's linked more to the tooth time contact as well. When the patient's elevator muscles contract, a force goes through the teeth. And so the more force you put through a tooth, the more you're overloading that tooth. And so, yes, clenching is one. But also, a patient who's got large, hypertrophic muscles, square jaw, you can imagine that they're going to put more force through a teeth. Now, I don't know of any great evidence that, Emma, your tooth, your premolar, your first premolar is way stronger naturally than my first premolar. I don't know if that's true. I don't know if, like, you put your tooth in the machine and put my tooth in the machine, that genetically, unless we have like amelogenesis imperfecta or that kind of stuff, but let's assume that me and you, our first premolars are very similar, maybe 1 or 2% difference, okay, genetic variation, okay, maybe Scottish enamel is stronger than Afghani enamel, okay, so it's probably true. So you can imagine that there might be minor difference. But if I have got like strong muscles and which I do in my jaw, and if I'm clenching a lot and you're not, the lifetime of how much force is going to go through that tooth is different. So it's force, and then that also ties in with diet in a way. Okay, now I don't buy that. Oh, we should avoid eating nuts. But however, the harder the food you eat, imagine trapping some food between your premolars. Okay, like imagine you put an almond, you put it between your premolars, and then you bite and you crush it. What happens is that the teeth overload the almond. The almond doesn't overload our teeth. Our teeth overload the almond. However, to be able to produce that load to crack the almond, some load had to be received into the premolars. Now, if you have a very big, hard diet, I mean, the worst are ice chewers. Imagine someone who just chews ice. So you have to constantly break ice, and how are you breaking it? You're breaking it with your cusps. What do your cusps have to do every time you clench together? They have to flex. So you're promoting cusp flexure. So diet actually plays a role as well. Someone who's an ice chewer, eating a lot of nuts, they are more likely, okay, it's not the only thing, but if they're also clenching, if they also got incline contacts, you can now imagine all those factors add up to someone having more cracked teeth. The other one that goes hand in hand back with tooth position is the fact that some people have more steeper cusp angles, and other people genetically have shallower cusp angles. Can you figure out why this may be significant, Emma?
If you've got deeper cusp angles, are you more likely to have that sort of incline contact?
Well, you're well done. You're more likely to have an incline contact, but also the following, okay? The patient, when they chew on ice or an almond, when you've got the steeper inclines and you chew on it, there's more flex, there's more pressure going in right in the middle, and there's more flexure versus the shallow one. And also imagine I give you a like model of a tooth, one with steep angles and one with shallow angles, and I told you have to break it with your hands, okay?
Yeah.
The one that's got steep, you get it and you kind of wedge in between and you can break it way more easier. If I give you a flat tooth and I say break this flat tooth, what are you gonna grip onto to break it?
Yeah.
It's just physics, right? So it's just physics. And so the last one is tooth time contact. It goes back to if someone's touching their teeth together for 18 minutes a day and that's it, that's completely different to someone who's doing it for 4 hours a day or 3 hours a day. They're touching their teeth together. So not one of these factors is more responsible than the other, but all of these together are resulting in overload of individual teeth and the systems. The muscles get overloaded, right? Everything is a system. Has this helped you to maybe, and be honest, Emma, is this useful to think about it in terms of tooth position, tooth force, tooth time contact, in terms of the triad of what can happen to a tooth?
Yeah, I would think so. It almost reminds me of like, you know, those diagrams and you see the triangles. That's what I'm picturing in my head. But I think that's so interesting, especially about the almond analogy that you used there. I've never really thought about it like that before in people's diets and things. That's really, really interesting.
I'm looking forward to making like an introduction to occlusion, and like, there's one way to explain it, and then I want to bring the joints into it and the muscles and describe it as symptom, talk about the importance of adaptation and the variables in occlusion. So that's a little starter piece. So I'm glad you like it. Now, going with that, there are certain teeth that are just evidence-based more likely to fracture than others, okay?
Yeah.
First premolars.
Okay.
Very prone to fracture, okay? And so these are teeth that are more prone to splitting, okay? So first premolars, second molars, okay? So first premolars because of that steep angulation that they have often, okay? Second molars, can you guess why second molars?
Just a large amount of force generated on those teeth.
Correct. Why is there more force being perceived through a second molar?
Closer to the TMJ, like the nutcracker analogy.
Perfect. It's closer to the fulcrum, the TMJ. The muscles are right there as well. Like, actually, where is your muscle? It's right there, okay? But your masseters are right there. And then also, when you're going to chew ice, where are you going to stick it? You're not going to stick it between your front teeth, right? You're going to put the ice right between your sevens and go for it. So, and also, if there is bruxism, okay, you're clenching and squeezing together, then that cusp flexure and the contacts and the strain is felt on those. Now, this is all from my just memory, right? It's first premolars, second molars. I'm trying to think, and then I think it's first molars. I'm going to now validate this, okay? Let's do a validation. Okay, so we're going to validate this, guys. I've been talking now, and this is from memory, but let's see if I'm right. I probably have made a mistake somewhere, but let's see. Cracked teeth, a review of the literature. And let's see what it says. Lovely, good. Oh, this you see. So those of you listening, there's some great visuals here. Again, I'll share this paper in the show notes. So when I share the American Association of Endodontics like guide on cracked teeth, which is awesome, and this paper as well. And let's find out. I think it's lower mandibular molars. Okay, so it talks about different prevalence and incidence. Okay, so most of the studies reporting the incidence and prevalence of incomplete tooth fractures agreed that cracked teeth were significantly associated with intracoronal restoration. So that's the first thing I said, right? If someone's got a large restoration, it will crack. And were most prevalent in mandibular molars. Okay, mandibular molars. So second molars and first molars. The highest prevalence rates appeared in patients over 40 years. So there we are. Okay, so why is that significant? Why 40 years? Why not 18 years?
Just over time.
It's that third part of the triad, right?
Yeah,
it's tooth time contact, right? It's a tooth time contact. So not only just during the day, but extrapolate it throughout life. And so women, okay, I have no idea why women being more affected than men. I think women are just more stressy. I don't know if I'm allowed to say that. Am I allowed to say that? Is that sexist?
Oh, okay. No, that's fine.
I can't speak for women. I'll speak from just my wife only, okay? My wife is more stressy than me, okay? Therefore, she's more likely to get cracked teeth than me. There we are. Fact, okay? I can't generalize about any genders and that kind of stuff, okay? Although one study showed an almost, I'm going to get cancelled, aren't I? Almost equal distribution between gender groups. Okay. Back, they got a little table in this study, right? And it looks like the study author, the tooth type, the incident rate. So mandibular molars overwhelmingly the most likely to crack, and then followed by maxillary molars and followed by maxillary premolars. But look here, how rarely mandibular premolars, right, fracture relatively. Okay. Can you figure out why that's the case?
For the mandibular
Yeah.
premolars.
So why is it that maxillary premolars are more likely to crack than mandibular premolars? This is really fascinating.
I'm just putting a guess forward, something to do with different bone densities down there, where you've got a more amount of bone on your mandible. I don't know.
That's an interesting one, Emma. You know what? It could have something to do with that. But okay, here's another. Oh, you okay? This is so good. Okay, so another thing you reminded me of is. Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. Have you seen many perio patients?
A few, yeah.
Okay. I don't know if you're maybe too young to have made this observation, okay? And I'm hoping some of the more experienced colleagues can be like, oh yeah, I've seen that. Is our perio patients don't tend to get cracked teeth. Their teeth look beautiful. Like their teeth anatomically don't look worn and they don't have cracks. They just look stunning. I don't know if you've noticed that.
No, I haven't noticed that. No.
Okay. Okay, so this is going back to something called the weakest link theory. Okay, now we're going to pause that for a second. Yeah, okay, you're saying you've seen the lectures on OBAB, so okay, well, we're talking about that. Okay, we'll come back to that in a moment. Okay, so we'll come back to the weakest link theory in a moment because you made a great point there. But the point I was going to make is the reason why mandibular premolars is, go back to anatomy, right? If you feel your lower first premolar, look how tinchy that lingual cusp is. There's nothing for food or a cusp to come into and split the tooth. If I had to have a giant version of a lower premolar in my hand and I had to crack it, I'd really struggle to crack that. Whereas a maxillary first premolar, oh yeah, I can grip onto those cusps and really go for it. Okay, so it's the anatomy of the teeth which is really, really interesting. And again, this is consistently reproduced in the studies that I'm seeing here. Mandibular molars most likely to crack, followed by maxillary molars, closely followed by maxillary premolars, and mandibular premolars very rare. So isn't that just a fascinating observation?
Yeah, it's strange.
So now we know we answered your second question. Now let's just touch on the weakest link theory, okay? The weakest link theory says that, and it's just a theory, but I love it because it explains our perceptions and what we see in the populations, which is that when you observe your patients, they've got something, like when there's overload in the teeth, there are certain systems that are affected. So it's either the periodontium that suffered this system, or it's the muscles and the joints, or it's the teeth, whichever is the weakest link. And quite often you have two of the systems affected together. Very rarely you have all three systems. So let's break this down. How does it actually work, right? And I think it's best explained by, why is it that the periodontal patients don't often get cracks or wear? Can you figure out, Emma, why a perio patient is less likely to get cracks and wear?
So over time, their teeth are going to become more mobile and almost move out of the way. They've got a bit more give in the PD.
Exactly, right? So when there's more give, when there's softer bone, when there's more mobility, right? And you're chewing on something hard, okay? The pressure has to dissipate somewhere. Now, on the opposite end of the spectrum, that big bloke with mandibular tori, hard, stiff bone that you're afraid to do an extraction on because you stick a luxator in and nothing is budging. Your luxator's going to break, but the tooth's not going to budge, right? That's the patient that gets the cracks. Because when they're chewing, the bone is not helping. The bone is not absorbing the force. The PDL is not absorbing the force. All the force is going into, all the stress is going in the cusps. But when you have a system or a patient whereby they've got a bit more give in the system, instead of the cusps flexing, it's the PDL taking the load away. I think we've touched on this before, Emma, previously, but it's worth mentioning again that someone who's got a grade 1 or grade half mobile tooth, that patient, if you use that tooth as a resin-bonded bridge abutment, will be more successful than a patient who's got no mobility and you use that tooth as a resin-bonded bridge abutment. Because when you load that bridge, the patient who's got really stiff, hard teeth or hard bone and there's no give, when you load that pontic, all the load is absorbed by the lute, by the cement. But when you've got a little mobility and you're chewing, some of the pressure is eased off, is absorbed by the PDL before it actually gets to hit the cement. It's the same kind of concept, and that really helps to explain cracked teeth. I'm really enjoying this. I'm hoping you are.
No, it's really, really interesting. I've never really thought about it. I know about the weakest link theory, but I never really thought to bring that into cracked teeth and things like that. So that's quite interesting. Another question that I did have for you, Jazz, which maybe you'll find this a bit boring, but we had in an OSCE scenario, it must have been BDS2 or BDS3. It was about diagnosing, I think it was cracks in teeth from memory, just like, extra points if you can answer these kinds of questions. And, I know that the answers are, a tooth sleuth, a bite test, transillumination, but I've never seen, I don't even know if that's available in Glasgow Dental Hospital, transillumination. Is that something that you've ever used before?
You know what, Emma? I've actually never used transillumination. Okay, I've just never had it. I've actually got the tip that you put in your light cure, but quite often it's a different light source something. I never bought it. I didn't have access to it. So it's one thing I haven't used, but I know that the light kind of stops. It doesn't go through because there's a break in the crack and there's a very characteristic appearance. And so no, I haven't used it, but it can be quite helpful. I'll tell you what's really helpful to me. just really high magnification, at
Okay.
least 5 times. 8 times is better. At least 5 times. Dry teeth, and having a really good look, good photography as well, and you'll be able to pick up these cracks, even in virgin teeth. And sometimes it's difficult to see if they're not stained.
Okay.
But when they're stained, they're further along the pathophysiology. When your probe is getting in there, that's really bad news. You've left it too late. You're really now reactive and not proactive anymore. Even though the patient's having no pain, if you can feel a probe, you can feel a crack with a probe. I think Pascal Magnier said it's something like 200 microns or something like that. So Pascal Magnier taught me that if your probe is getting in the crack, that's like 200 microns at least resolution. Whereas when you're using high magnification, you can actually detect cracks that are way smaller than your probe ever could. So if you're just relying on your probe, you're leaving it too late. You really need high magnification. I don't trust any dentist that doesn't use loupes. Honestly, like you must. I would let anyone anywhere near my mouth without magnification.
Fair. Fair. Okay, so is a tooth sluice something that you have in your surgery?
Oh, of course. Yeah. I think tooth loose is very common. They're autoclavable. They're ready
Yeah.
available. And so I think that, the good thing is you can test cusp by cusp, and then the patient bites together. And then one cool thing that that Krina taught us in that episode, I think it was episode 28, all those years ago, is that what I used to do is you put the bit that slots onto the cusp, get the patient to bite together, but then just give it a tiny wiggle. Give it a tiny wiggle, okay? When the patient's biting together, that helps with your diagnosis, basically. So tooth sleuth is one aspect. Doing cold testing, see what kind of response you get. Visually taking a look. Yes, there's transillumination, but it's something I don't have experience with. But very often it's like, the epidemiology. It's mandibular molars, maxillary molars, maxillary premolars. You kind of know which teeth are more likely. And then you look at the patient, right? You look like, okay, if they're missing teeth on the adjacent side, find out why were they taken out. Because quite often, it's like someone who's had difficult extractions in the past, that's the best predictor of a difficult extraction in the future, is that. Right? And so if you've lost teeth due to cracks before, then not only do you have to be more vigilant, but you have to then consider that, okay, I'm probably dealing with a cracked tooth again. The past is the best predictor of the future.
Okay. And if you see a crack in a tooth, and if you've got a radiograph and you can't see much on the radiograph,
you won't. So with a radiograph, it's very rare. I've got a radiograph I took this year that shows a crack beautifully, because the crack, the plane of the crack just happens to be exactly going down like the plane of the X-ray. But very rarely does that ever happen, basically. So it's extremely rare. It can happen though. But you very often, we're only taking a PA just to confirm what is the apical situation, but the radiograph is not going to help us that much when it comes to crack diagnosis.
Okay.
It's a clinical diagnosis.
Right, okay. And if you're seeing no periapical pathology on the radiograph, is often, treating that crack and the symptoms in the teeth is going in and removing the crack and seeing where you end up. What's sort of the treatment options for that?
Really good question, because now we're getting in decision-making, treatment planning. This is a wonderful question. And like with everything complicated, everything occlusion, that kind of stuff, it depends, unfortunately, okay? But let's talk about what it depends on, okay? Because if you just leave it as depends, then that's no good. But if we talk about, okay, what does it depend on? And play different scenarios. And I'll give you real-life scenarios, okay? I have a 19-year-old patient, okay? She's got huge mastus. Huge, okay? She is a major clencher. I've confirmed on something called a Brux checker, and I'll put the image here. Her parafunctional pattern one night is just so broad. And she's got huge muscles. Every 2 years, she destroys her splint and she gets a new one. But before she ever started wearing splints, okay, she's just 19. She's just 19, and she presented to me with a crack in a virgin lower first molar. And so the first time it presented to me it was symptoms. And so really, I had to really dry the tooth to see it. I was like, oh, wow, yeah, there is a crack there. It wasn't stained, but it was symptomatic. For this individual is a completely different treatment to someone who's 56 years old and they've got a giant MOD amalgam, and you diagnose cracked tooth syndrome. You know that the giant MOD amalgam is going to get a crown or an onlay or something, right? Okay. Whereas the 19-year-old is a distal crack. Would I really want to do, reduce the cusp by 2 millimeters all the way around on a 19-year-old? So what I decided to do on this 19-year-old is, okay, well, if the crack is distal, let's explore distally. What I'm going to do now, guys, is those who are listening on Spotify and Apple, I'm going to keep it very descriptive. I'm going to show Emma some photos. If you're watching on Protrusive Guidance on YouTube, you got some visuals, but don't worry. My numero uno are always the audio listeners who've been with me since day dot. Okay, I'm going to make sure you're not feeling alienated. So the first image I'm showing you, Emma, is an Essex retainer, because she's had orthodontics before, absolutely destroyed, right? So.
Yeah.
And then what's the next thing you want to know when you see an Essex retainer like this? What's the next thing you want to know?
When you see an Essex retainer like this,
When you see a destroyed Essex retainer, like chewed up, okay,
like how
what
long
you
they've
want to
had
know
it for?
is, there we go, okay, because if this has been like 7 years, I'm like, okay, that's fine, I can deal with that.
Okay.
But if this is 6 months, which is what it was, what can that tell you? What information do you now gain from seeing this retainer after 6 months? And it's in this state, chewed up, holes perforated.
Yeah, a lot of, prolonged tooth time contacts.
Wonderful, beautiful. Tooth time contact and tooth force. Okay, so it's a combination of the two, and even position, because there's a lot more back tooth contact than there is front tooth contact, right? So that's kind of leading to it as well. So anyway, she comes to me. Let's see. Yeah. So here's the situation. The lower molar, we said. This crack, right, that I'm showing you, and those are listeners. Okay, it looks fairly harmless. Okay, it looks like a fairly harmless crack. Like this, we see this in teeth all the time, but she's complaining of symptoms. And she's just 19, but she's a high force patient. Now, on the photo I'm showing Emma, there are some articulating paper marks. Okay, so I'm firstly highlighting my mouse around a cusp tip contact. Okay, that's a cusp tip contact there. And then here, okay, it's on the occlusal table of the cusp. But can you now describe what kind of contact this is?
An incline contact.
Well done. So I'm showing Emma an incline contact. The dot is not in the fossa. The dot should be here. But actually, the dot or the smear, the large contact, is actually, halfway up the cusp. No wonder there's a crack here on this high force patient. Okay. Now, just to confirm, I didn't need to do this, but because if you had the retainer as evidence, but we did something called a Brux checker, and a Brux checker is like this thing, which is like painted red. Your patient just wears it for one night. And then anywhere there's tooth rubbing going on, like the ink wears away. And it's not like every time it touches, the ink is gone. It takes a fair bit of effort to rub this ink away, which is important because you don't want like a false positive, right? So you can see how much force is going down the molars, and actually she's bruxing onto her front teeth as well. But this just confirms that, yeah, for sure she's a bruxist. And we have the incline contact. Again, I've got blue ink here now. And then there's an aggressive cusp of the upper molar. So the other thing that you see on this molar is on the mesial half of the molar, this part of the tooth, right, guys, it looks completely like a 6-year-old's tooth. Look how pristine the anatomy looks here, right? And then now, when I move the angle of view to the distal half of the same molar, can you see how aged the tooth looks? So my question, guys, for those listening is, why would that happen? Why would one half of the tooth look like pristine? Nowhere. And the other half is the one that's got the crack. It's got some wear. It looks like it's been in the mouth for far longer than it has been.
Is there a...
It's not a trick question, but it's something that, is an interesting discussion point when we look at the tooth level. Go on.
Is there a bit of like a rotation on the opposing tooth?
Beautiful. So essentially what you're saying, Emma, I mean, it may or may not be rotation, but what you're thinking of is the opposing tooth, right? So imagine the best way to describe it is imagine the mesial half of the tooth doesn't have an opposing tooth. Imagine it's a missing tooth. But the distal half of the tooth hasn't. It's as basic as that, for example. I'm just making this up in this scenario just to help to explain the point. But when you see some damage on the cracked tooth, you always must, it's a lesson I'm teaching you guys, look at the opposing tooth. Because that will give you a clue, right? Often there'll be something sharp there, something that's gonna, like a dagger, something that's gonna be damaging there. So always look. And actually, a great point to consider is if all you do is remove the crack and put a composite, the composite will also fail through overload eventually. If you do not change something about the upper tooth, i.e. lightening the force there, or changing it from a sharp dagger to a rounded, softer cusp, or maybe changing it so that now you're converting it from an incline contact to a cusp, to fossa contact. So you must change something about the environment to reduce the crack propagation.
Okay.
Anyway,
Yep.
so what I did, guys, for those listening, is I actually reduced the incline, the angle. Can you see I reduced the angle? So now I've
Yep.
actually converted this tooth from a steep angle to a shallow angle.
Okay.
And some
Okay.
people may be
Yep.
saying, on a 19-year-old, you removed enamel? Well, listen, this 19-year-old, if I didn't do this, she'd be the 40-year-old with a virgin tooth who has split her tooth because all the dentist said the cracks were harmless and then she lost her
Yeah.
tooth, right? So we have to sometimes be appropriately invasive to preserve tooth in the long run. So I have to sacrifice some enamel now. That's what occlusion is all about. Practical occlusion is all about these decision making, actually taking birth to a tooth and doing that for the greater good. And so you can see when I explored the crack, okay, you can actually see it quite clearly now, right?
Yeah. Yeah.
And what do you often find in a crack? You find caries. Okay, so
Okay.
can you see there's some caries? So guys, I'm showing Emma some caries, which was not present
Right.
radiographically, right? But wherever there's crack, there's demineralization. It's the entry point of caries. So thank goodness we intervened. And we didn't allow
Yeah.
this to become worse or bigger and actually become radiographically evident. I restored it with a composite. And what I didn't do is I didn't just recreate the old anatomy and make it steep again. I kept it shallower. So now the opposing palatal cusp, when it now grinds on this molar, is doing so in a shallow way. And what I'm showing here, guys, for the audio listeners, I'm showing an image which is just one of my favorite images in education. Okay, because that point I made about the mesial half of the tooth looking good and the distal looking battered, but now you see this across the first molar and the second molar.
Yeah.
It's like this tooth is age 19 and this tooth is age 7. Like the distal half of the tooth is age 70, and so it really drives home the point of tooth contact time, tooth force, and tooth position. All those things that I spoke about earlier are being manifested here. And so her pain went away and everything was good, except actually she's having the same issue on the left side, and I ended up treating her left side as well. So you have to look at the patient as a whole. And the main lesson here, guys, is if you're treating a cracked tooth, your treatment modality will depend on how old the patient is, how bad the crack is. So here for her, composites, but not just a composite, is composite and careful and judicious adjustment of both the existing tooth angles, where the occlusal contact will be, and being purposeful for that, and doing some opposing adjustment to remove the noxious stimulus.
Okay. Yeah, that's really, really interesting, Jazz. And I think it's fun because, I usually just spring these questions on you. I usually ask, oh, do you want me to send you over the questions that I have in advance? And you're usually like, no, let's just go for it and see what happens. But I think it's really interesting that you had such a good case to show there. I thought that was really, really interesting. That was really interesting.
I've got great images as well, guys. I'll put them on the app on Protrusive Guidance. But like when you aerobraid teeth, once you remove that amalgam and you aerobraid, you will see the cracks pop out at you. So if you're not able to see the cracks before, when you aerobraid, suddenly they all come out of the woodwork and you can see the cracks basically. So really important diagnostic tool. And so the final thing to talk about, running out of time here, but communication. That's the thing that stressed me out the most, because the patient's like, hang on a minute, vast majority of patients who've got cracks are asymptomatic, because not only do cracks come in a spectrum, but the patient, I guess, development or progression of a crack also comes in a spectrum. At what point they present to you in life and how proactive you are. And so if the crack has just formed and is barely in enamel and just about entered the dentine, they have no symptoms, you might even miss it. In a quick exam, you might even miss it, right? Then they come back, the crack gets a bit deeper. A few years have passed by and the crack's getting a little bit bigger. Maybe it's starting to stain now. And stain is significant because, do you know why stain is significant for a crack?
Does it go back to possibly caries in there?
Kind of, because a crack can only stain when it's wide enough to allow the stain particles and bacteria through. So basically, if the stain's getting through, we know the bacteria is getting through. So vast majority of these cracks are completely asymptomatic, but it's up to us as the dentist to take photos to explain to the patient that, okay, you may be low risk caries, you may be low risk perio, but you are high risk of cracks. You have 4 cracks, 2 of which I think are going to be okay, but actually the other 2 I think are a bit concerned. I think let's watch this one, but I think we need to investigate for the other one. So cracks come in all sorts of different presentations, so it's up to us to lead the patient and really advise them and let them own their problem. And it's like, listen, the crack is in your mouth. You have overloaded your tooth and caused this crack. I can help you, and this is what we take. But a cracked tooth is a really upset tooth. The nerve, Even though you're not in pain, the nerve is always a little bit traumatized from a crack. We will try our best to do it, but I wish there was no such thing as cracked teeth, because cracked teeth really reduce the chance of your tooth surviving throughout lifetime. So if you want to give your tooth the best chance, we can restore it now with XYZ restoration, but know that the nerve may already be damaged. We'll only find out. If we do nothing though, then you're heading towards a split tooth, and these things, they don't just appear overnight. They all start like the crack you have. And I can't predict with your diet and with your clenching how fast it will progress in your case. And very often, you're monitoring photographically, you're monitoring symptoms. Very often with general practice, we have this beautiful relationship we get to form with patients. So very often we see these patients year on year on year, and we mention, okay, yeah, that decay is doing fine, it's not progressed. The crack on this tooth, however, based on my photos and what I remember, I think this one's got worse. And by the time you've been seeing them 4 years, they trust you, they get it. Okay. And it's one of those things where patients are unless they have a relationship with you, something that doesn't hurt them, they won't really, something that doesn't hurt them, and B, they don't want. No one wants to have their back teeth drilled for cracks. Okay. If it's aesthetic dentistry, then they don't have to trust you. There's something they want, they'll go for it, kind of thing. Right. So it's one of those things. Cracks that are asymptomatic can very quickly lead to tooth loss. And that's why the communication element really comes into it.
Yeah, that's really interesting. And I think I was going to ask you before, like, what your number one piece of advice would be, but I know that you already said, like, look at the patient as a whole, and especially looking at the contralateral tooth on the other side, and also the opposing
contralateral, opposing. Look at them, the shape of their jaw. Are they got, when you get them bite together, have they got giant golf balls that come out as masters, or are they very gentle? Okay. And these things are so important. What do their retainers look like? What do the other teeth look like? What does the opposing tooth look like? Does it look like a plunger cusp that's right overlying where the crack is?
Yep. Yeah. So very, very interesting. And I like you just had to hand all the photos that were so helpful in visualizing that there. So that's good. I like this episode.
Amazing. Brilliant. Well, which notes are you going to make available to all the Protrusive students for this time round?
So I know that the American Endodontic Society has really good notes on cracked tooth syndrome. And I can just release anyway. I know we were going to do a boring episode about medical histories, but I think decided against that. But I have some really good notes on that anyway, so I
would
might
love
just
that.
attach
I think everyone, it's such an important thing, right? Medical histories. It's just so boring to talk about, and there's like, where do you draw the line, right? So I think let's make this available, because students will need this for their exams and stuff. So let's make medical histories available. It's not really relevant to crack, so we're giving you something clinical and highly actionable and relevant, and something that hopefully will stay with you for life in how you practice and how you look at crack. You never look at cracked tooth the same way again after this episode, right? But now you also have medical histories to keep your examining board happy as well. So all that is available on the students' Protrusive section. And of course, all our Protrusive on the app, you all have access to it. Whether you're a student, young dentist, experienced dentist, it's always nice to listen to a different way of explaining things and connecting back with the basics. The basics can be beautiful.
Yeah, for sure. And it's easy enough to answer these questions in an exam, but when it comes to actually doing dentistry and being dentist, it can just take a little bit more explaining.
Well, Emma, thanks so much for your time. All the best with the rest of your final year. We'll catch you in the next episode. Have you got an idea of what you want to talk about next episode?
So I think when I've been in outreach centres recently, I've been seeing a lot of failed composites, not from me, but from previous students before. So maybe even a conversation about that, who, where, what, why, when went wrong, failing
Beautiful.
composites.
Again, another clinical topic. I love it. There's so much we can talk about. Okay, excellent. Let's talk about failed, maybe well, we can talk about failed composites in general, because there's a whole adhesive protocol, there's the occlusion management, there's a layering management, all that kind of stuff. And then some things we say will be more applicable to posterior teeth, some to more anterior teeth, and we can talk all about that. Amazing. Okay, I'll look forward to it. Thank you so much, Emma.
Perfect. Thank you.
Well, there we have it, guys. Thank you so much for listening all the way to the end. Please do answer those questions below to claim your CE. We are a PACE-approved education provider. Hope you enjoyed my take on occlusion in terms of position, force, and time, and how the combination of these result in overload, which is the ultimate cause of cracks. If you did enjoy this episode, please comment below. Tell me what was your biggest takeaway from this episode. If you're watching on YouTube, hit subscribe. If you're watching on Protrusive Guidance, A, don't forget to answer the quiz, and B, it's always lovely to read your comments. I hope you're enjoying these kind of basic student-based series, but as you can see, it's not really for students. It's a nice geeky chat on some of the fundamentals, and there's beauty in the basics. I want to thank Team Protrusive as ever for all their hard work. I'm thanking you once again, Protrusive RT, for sticking around. I'll catch you same time, same place next week. Bye for now.